Next presentation is by Dr. Debashish Datta, Negative Dysphotopsia and Enigma of the Past.
Good morning, everybody. So negative dysphotopsia, an enigma of the past. Negative dysphotopsia is a burning question. It is ubiquitous to all in the bag lenses. In immediate post-operative period, the literature says the incidence is as high as 12 to 45% and even more. Now, given the number of cataract surgeries done in India and the number of phacoemulsifications done, in the immediate post-operative period, the burden in India is about 8,34,000, and which boils down to about 1,20,000 patients each year, adding to the burden. So there are various management strategies which has come into place to prevent negative dysphotopsia. Reverse optic capture, primary or secondary, and back to sulcus IOL exchange. These are the two important things which we do. The aim of the study is to find out the incidence of negative dysphotopsia if we place the IOL in an unique way. So what is that? Let's see. So the sulcus placement of IOL will lead to this derangement of the effective lens position, and centration will be at stake. And reverse optic capture will bring the optic edge out of into the below the iris, leading to iris chaffing and release of pigments. So how do we take care of these two things? If we can place the haptics in the sulcus and put the optic in the bag, it gives us best of both worlds. So we don't have a pigment release, and the the sulcus is the plane of placement. So we designed a study. It's a descriptive, observational, non-randomized, consecutive retrospective study from April to December 23. All routine cases were taken into account using a hydrophobic intraocular lens placed in the sulcus and ensuring that the optic is aptly captured inside the rhexis margin. Now it's a double masking is done. Even before the patient reports for a follow-up, a telecaller caller calls up the patient on the 2nd, 3rd, and 90th post-operative day to make sure whether by giving questionnaire and by asking the patient whether he or she is having negative dysphotopsia. Now there is a short video whereby you see the first haptic going in the sulcus, the second haptic being dialed into the sulcus, and the edge of the optic is nudged below the rhexis margin. It's a magnified view only. And the edge is negotiated below the rhexis margin. So it's a rhexis capture is done. So this is the post-operative period. You can see the rhexis margin clearly, haptics out of it, optic behind it. The sharp edge of the optic is below the rhexis margin. So it cannot cause iris chaffing. The results, it's a cohort comprised of 223 patients, and we found only 8 patients develop negative dysphotopsia. So it boils down to 3.5% vis-a-vis 15 to 45% and even more in the literature. So 1 month post-operative and we are not concerned because anyhow the thing comes down. So what does this study add? The reduction of negative dysphotopsia through strategic placement of the IOL, and future innovations of IOL design and surgical practice can be done depending on it. It has been ignored for long. We tell the patients it will go off on its own. Don't worry, don't worry. But with the advent of the premium IOLs, everything, if the patient comes on the next post-operative day with a premium lens and says, I see a black shadow, and you are answerable to him or her. So this thing will help in designing of the lens and predicting a better outcome. Thank you.
Thank you. Very good study, Dr. Debashish. So is this study holding valid only for the 3-piece lenses?
You see, at the present, I have done it within the 3-piece lenses. Otherwise, it will raise eyebrows because single-piece lenses are not allowed to be placed in the sulcus. So for this thing being proved, then we can go on. Like trifocal lenses, multifocal lenses. We used to have rezoom lenses, multifocal lenses, multi-piece multifocal lenses. So then we can venture into all those things.
A good sample size and statistical analysis. Thank you.
Have you compared with the, suppose we are using piggyback lenses in the negative dysphotopsia?
Those are the, yes, options, AIOC capsulotomy, truncation of the nasal edge of the lens, piggyback lenses in the sulcus, all these things are, but this is anybody, anywhere can do.
But the limitation to this is that the single piece lenses at present.
That's why I said we can take into consideration the design thing. If this is proven, we can design those things with the single piece lenses or proper haptic design with the proper optic.
Thank you very much.
Thank you so much.